great.
Sorry.
No worries. Technical difficulties happen. But it
Yes.
looks like our attendees are coming in from the waiting room, so we can begin. So thank
Perfect.
you, everyone, for joining the CADASIL Consortium for our webinar today. Our speaker today, Dr. Karen Orjuela, is a vascular neurologist, and she'll be speaking on emerging research trends and findings in CADASIL research, followed by time for Q&A, where questions can be inputted into the Q&A box below. Thank you again.
Thank you, Iman, and thank you all for joining. Sorry that we're a little bit late. I had a quick, I had to troubleshoot a couple of things in my computer. It's going to be a little bit tricky to know who is in the room, so please write your questions, and I'm going to ask Iman to let me know what questions are in the box, since I have a little bit of like technical issues on my side. So thank you so much for joining. I hope this is a useful conversation. I'm going to probably start talking since the format is a webinar, but please leave your comments in your Q&A. And if I don't know the answers, definitely we are a big community, so I can ask for the right answer. So I was asked to bring a little bit what I learned from the international meetings. I have to say, full disclosure, I'm not the primary investigator of a lot of things that I'm sharing here. So I try to cite as many of my colleagues and researchers around the globe. So please also be mindful that I don't have all the answers for this, but I took a lot of notes during the meetings, and this is sort of like a curated collection of input and information from what I've been learning the last couple of meetings that I attended. One was the Global CADASIL meeting, or it was an interesting meeting of researchers that we all met in Paris last year, and the most recent International Stroke Conference in LA also this year. So my name is Karen Orjuela again. I'm really happy to be here. So we're going to have a couple of objectives. One is I'm going to try to present detailed research findings from the recent meetings about CADASIL. And I'm going to explain sort of like the clinical and research implications for patient care and trial design. And ideally, we have like a couple of minutes at the end to have like that open discussion and about this subject. So what I want to probably say that is kind of like hard to sort of like summarize what is happening in the world of CADASIL research, because there's a lot of new things and new advances, and of course also learning like you about all these things. So summaries that we can probably say they're mainly these big topics. One is sort of like this communication between what we know about genetics, imaging, and biomarker studies. We're going to learn a little bit more about insights from long-term clinical studies and preclinical animal models. So we have that information too, some information and updates on therapeutic exploration and patient-reported outcomes too. So I'm going to start with, and again, this is a curatorial. I curated this, basically things that captured my attention, but is by no means all comprehensive of all CADASIL research, okay? So during the Global Consortium or the Global Meeting, I learned and I met Dr. Marcus, who shared and the work of his team and the ongoing efforts and trying to understand this global perspective in CADASIL with genome-wide association studies. So trying to analyze this genome characteristics in CADASIL and MRIs, and trying to understand the difference for like genetic mutations and how that specific, for example, epidermal growth factor receptors that are specific locations of this Notch3 mutation affect clinical presentations in patients. So, for example, there is sort of like a way of organizing the information in our genetic system too, and the location of that information and how this information is packed into a gene where is that gene located? Tell us a little bit more about how this information is going to be processed and translated and activated throughout our life. So in this sort of like analysis, this sort of like location of this information packed into a gene that we know that is in NOS3 show us, for example, from the 1 to 6 mutation, we know that they have like higher history of a stroke when the mutation is located in these mutations. So, and they analyze a lot of sort of like NOS3 pedigrees, so a lot of family members, and try to find out different sort of like common information from that. So what is this? Again, this location, and that status correlates with different characteristics that we know that affect the tiny little brain vessels. And if the age as a presentation of initial cerebrovascular event, like a stroke, could be used as a clinical sort of like metric, because most of the time we know about this disease when patients consult for this type of abnormalities too. So what does it mean for us and for you? Perhaps is like more precise genetics or like classification and stratification may give us more input into risk assessment and personalized monitoring. So we're going to probably be able to tell a little bit more, not only about the mutation, but also the location and what are the implications about that information packing to the gene is going to be translated into information later into proteins, and how that is going to affect your daily life. Also, another study that captivated my attention was the advanced brain imaging with sort of like a special filter and MRI, and how these tiny structural changes in the white matter helps to quantify early changes in the small vessels in the brain. So how can we be really, really looking into these tiny little structural changes in the white matter in the brain could help us determine a little bit more changes earlier than when it's just very florid and when we probably can reverse things. So how can we move towards a more early diagnosis? So also not only looking at the gene, but also looking at the imaging, at the pictures, and how can we track disease progression is also something that is coming up in the future. One is important fact also from our colleagues in Japan. They are teaching us from their experience a little bit more about this disease specifics or how this disease manifests or presents in different populations with different ethnicity or different ethnic background. So for example, Dr. Ishiyama's team show us that in this mutation from the NOS3, the PR75P, that is a cysteine sparing mutation, that is identified in Japan and Korea, this mutation can have a little bit more presentation of bleeds in the brain than actually people that have more European ancestry or other ancestries. So that tells us a little bit more of the importance of being understanding a lot of not only one single gene, but we're more about the ethnicity, the background of every patient too. So we know that there are diseases that can change according to ethnicity background, so and ancestry. So I think that this is an important sort of like understanding also for our CADASIL community and research community of be as global and comprehensive in our research efforts for that matter. Also, we talk about information, how we pack this information in a gene, how location matters from where the gene is located, and how the information is going to translate to other things. We talk about imaging, how can we detect changes early, and in that way we can prevent things to develop in the future. We talk about geography, importance of ancestry and geography as well. But now we're going to probably try to say, with that, what is all that have in mind or common? We have a common denominator is that we are trying to to include the word early. How can we prevent progression of the disease? How can we avoid the symptoms that we have or we know that CADASIL might have? Understanding there's a lot of variability. So a lot of this work, for example, Dr. Carvelas in New York City, here in US, talk about like plasma proteomics and how can that give us more information about vascular and neural health. So how can we find more biomarkers or markers in our blood that can be linked to different or like information of CADASIL? So finding potential pathways involving vascular dysfunction, and also not only the vessel's health, but also the structure around what kind of like that blood and information sort of like distribute into the white matter, the cortex, etc., to avoid neurodegeneration or structural abnormalities. So developing blood tests might predict disease progression of treatment response. So once we get there, so we're kind of like trying to get a lot of information from different sources too. This is one of a study that captivated also a lot of my personal attention as a neurologist and someone that talked to you in a daily basis as far as like what to expect. And there is a lot of information out there, but I think that this is a good sort of like observational study from a cohort of patients that we know, of course, the different characteristics of the disease, but in this cohort in Cambridge in UK, they found out that there were progressive improvements in patient outcomes. So meaning that they saw reduced stroke and dementia presence incidence over 23 years. So what that means is that perhaps we are advancing detecting this disease early. We have perhaps better management of cardiovascular risk factors, things that damage the brain vessels as well, and the overall structure of the brain, like blood pressure, cholesterol, and other things that could affect and involve in brain health that we now do as a general sort of like practice. So that improvement of clinical care have possibly impacted long-term prognosis. So in patients that were followed in this more recent cohort, they found out that the age of onset of stroke was different from the prior one, the patients that were recruited before 2016 versus the patients that were recruited since 2016. So there's a lot of, being a little bit of hope, but because despite that we don't have a perhaps a specific cure for the disease, we can see that maybe doing things as controlling perhaps vascular risk factors such as smoking, blood pressure management, etc., could help to improve the outcomes in CADASIL as well. So I brought this table from the article that Dr. Hugh published with his team. And so I'm going to read this because I think that this is an important study. So what is already known on this topic? So CADASIL is the most common monogenic form of stroke. So initial reports suggest stroke occurring in the 40s, but the perception of many clinicians is that the disease may be becoming milder with increasing numbers of patients remaining stroke and disability free at later ages. What this study adds in this large, meaning longitudinal, there's follow-up, has a follow-up over time prospectively in the future, recruited CADASIL cohort, the age of onset of stroke in patients with CADASIL increased significantly over time of recruitment. So patients recruited since 2016 had a lower risk of both stroke and dementia. Additionally, survival analysis showed that patients who stopped smoking at any time had a significantly higher probability of remaining stroke and dementia free. So we know now that if we control or like external risk factors that could cause this kind of like double impact in brain health, we can improve already the health or make the outcomes as far as stroke and dementia much better. So how this study might affect research practice or policy. So this study provides updated risk estimates which can be used when counseling patients with CADASIL on prognosis, and it emphasizes the importance of treating cardiovascular risk factors in CADASIL. So I think that there is a lot of hope that even though what we think that seems logical, when we do it, actually changes the outcomes and prognosis in patients with CADASIL. So moving on to other sort of like symptom onset and recurrent stroke. So we know that CADASIL has a lot of different variants, right? So depending, again, the location where your mutation is, what we call penetrance, so how that information affects an individual. We know about like environmental risk factors, like smoking, additional cardiovascular risk factors. So in this important study too, Dr. Sheng from Taiwan tells us a little bit of a specific variant for their population, that they found that for variants in different sort of like location of this mutation, have a different specific profiles that require, again, more tailored patient management and risk counseling. From if that participant patient have a different variant, the R544C, it can have different presentations according to that as well. So meaning that where the problem is also within the gene is important too. And now we're looking also as another biomarker of the disease too. So Dr. Skatova in Portugal tried to measure serum levels of NOS3 extracellular domain to assess disease activity. So not only trying to say, okay, maybe we know that disease progress perhaps with a difference for like speeds. If there are different sort of like abnormalities in our body, etc., perhaps the information of the NOS3 could sort of like take speed or different speeds too, so that disease activity maybe could be monitored in the future too. So that will be a non-invasive tool of monitoring disease severity and progression over time. So one is, of course, taking care of early diagnosis, as we talk with different modalities. The other is like, can we know how is disease is taking like different speed levels? How is disease responding to different treatments as well? So I think that that's an important advancement too. And in that sort of like category of monitoring disease activity, we have sort of like understanding that there are maybe some patients that have rapid versus slow sort of like progression. And why is the brain or any or this pathology sort of like acting different individual? We just start to understand that that information from different fronts. Dr. Sophia in Paris is trying to try from the biostatistics, saying like if we can perhaps create a better modeling with different information, multiple inputs, meaning someone has different clinical characteristics, imaging findings, maybe we can try to predict better using mathematical models of rapid versus slow progression as well. So enhances our ability to predict disease curves and tailor interventions accordingly. So there's a lot out there. One of the things, sorry, this is a duplicate. One of the things, of course, is sort of like how we can understand the whole picture. And I think Dr. Jutel, who dedicated her life and studying CADASIL as well and trying to understand from the animal models, is trying to raise an important question. Like, we have limitations from our animal models too, like what we call preclinical. But it's an important also debate of like, is it a problem in CADASIL of accumulation of this protein, or also a problem transmitting the information, meaning the signaling of the information could be also affected. So it was very important to kind of like hear from Dr. Jutel that there are potential limitations of these mouse models in replicating, of course, the complexity of the CADASIL patients and their experiences as well. So I'm gonna move on to kind of like take a little bit of a breath. If you want, if you have any question, if it's too much, let me know. But there's a lot of information out there. I literally tried to kind of like pack what I found more interesting in a very selfish way. But please let me know as well what would you like to hear as well. There are a couple of quick notes that I took that I think that were interesting from younger investigators too, and more seasoned investigators too. Of course, ApoE is a gene that is very well studied in another pathology like Alzheimer's. So perhaps it might have a different role in CADASIL in investigating in animal models, how it impacts on disease progression. So another gene that could also be having some relationships with CADASIL as well. From the more clinical perspective, Dr. Zacharias in Italy tried to establish how different sort of like domains in the epidermal growth factor receptor, it was correlating with different migraine prevalence in their cohort, in their center as well. Dr. Gravenstein developed a scale of severity of the disease, the NOSH3 small vessel disease scale. And that is available in JAMA Neurology as well in one of the scientific publications. And that helps us as a clinician to try to monitor patients and try to understand different sort of like language among clinical studies too. And another way is like, how can we understand this disease, trying to modeling, right? Like trying to understand from the lab, from the math, from different sort of like data sources, how can we make sense of this pathology as well. So the other important sort of like approach that we have in CADASIL is trying to understand this problem as a team. And it could be a team of 2 people, but it could be a team of the entire world. So I think that we are learning that ethnicity plays an important role in this disease. It's a genetic disease, it's a familial disease, so family matters. So understanding from the geography perspective, or more importantly, ethnicity perspective, or ancestry, the registries are creating that organized collection of information that we call a registry, that sometimes we follow them up on time is important, and being as much inclusive of these different ancestries is going to provide us more and more information. So the CADRI registry in East Asia, and they did a study that focused on adrenomedulin as a therapeutic candidate for CADASIL. So they try to assess the vasoactive and angiogenic, meaning that it's creating of new vessels, anti-inflammation and antioxidative effects of this medication. And they found that it might be a potential for disease modifying treatment targeting neuroglial vascular unit. Of course, there's a lot from here to go and see if this could be a really good therapeutic candidate, but a lot of what we know is being done in different geographies too, and we need probably to corroborate if that works in our own population with different ancestry background too. There's a lot of different new clinical insights too. So as we talk about the East Asia cohorts, there is a Scottish CADASIL cohort as well. There's a Taiwanese variant cohort as well. So they have a different sort of like clinical variant that they have more intracranial hemorrhage with fewer sort of like what we call the white matter hyperintensity. So there is different presentation. They tend to have a little bit more bleeds in the brain, patients with East Asian ancestry as well. And if they have that variant, perhaps it's something that we will anticipate as well. Dr. Chabriat's team tried to explore what was the willingness of different population or at risk of developing CADASIL, of enrolling or participating in clinical trials. So a lot of the participation in participating in clinical trials was driven by a symptom onset, but that was important barriers that of participation of clinical trials were the disease impact, of course, what was the support that they would probably get, etc. So I think that is an important constant communication with you all of trying to understand what will require to advance research in this area. And most recently, during the STRIC meeting, we had a session that Dr. Paulson attended, and Dr. Chabria and other important PIs and researchers around the globe, where they present a lot of information regarding CADASIL. I brought this publication, and what is important about this publication is that they try to say, okay, we know that there are different lesions in the brain, but how this structure, this network, is preserved in CADASIL or not. So functional connectivity, they try to understand this from the mice perspective, so preclinical, and with these different sort of like characteristics in the mutation of Notch3, and they try to compare brain connectivity between different mice as well. And they saw that different mutations cause different sort of like brain connectivity and more movement abnormalities or challenges. So even though the brain lesion size in these mice were similar in both groups, but the connectivity was different. So now we have another kind of like layer of complexity that is not only the structural challenge that we see that are able to kind of like identify, but also how these networks are affected or resilient too. So this model helps us understand brain changes in CADASIL, and will be useful for testing future treatments as well. So I know there are different questions in the chat, so I promise I'm gonna probably try to finish very soon. So next steps, what I think, and again, this is a personal view, a lot of perhaps bench researchers or PIs maybe will differ about next steps, but I think that there's a lot of ongoing efforts in enhancing imaging, trying to understand genetic profiling and biomarker validation, meaning that things that I can test in the blood, things that I can check in the genetic profiling, being as precise and specific, and trying to see more things, not only from the structural sort of like reasons, microstructure, connectivity. So how can we put all this information together? How can we make CADASIL more global in novel treatments? And how can we learn from you what does it mean, a good outcome in any clinical trial? What's on the horizon? So we, of course, need to refine better clinical trial designs based on recent data, much more data. We have a little bit more understanding of this disease and what to do next, and expanded opportunities for patient participation in upcoming studies from all geographies. That's a huge challenge. So how can you stay informed and engaged? Of course, continue communications. You are here already, or you are seeing us in another sort of like asynchronous time, but the fact that you have updates through newsletter, webinar, support meetings, I think that that's super helpful. And being involved, your experience and feedback are super critical and very important to shape the future research and care strategies of this of this journey. So again, key takeaways: recent advances refine our understanding of CADASIL genetic, imaging, and clinical profiles, and this ongoing research sort of like is paving the way for more personalized care and potential new therapies. Even though it's just one mutation, we are understanding there is a lot of different complexities of how this manifests in different person or different people. So thank you so much. I'm gonna stop right here, and I'm gonna probably let's stop sharing, and I'm gonna probably try to answer or address some of the questions too. Will that be okay, Iman?
Yep, that's perfect. And it looks like we already have a couple of questions in the Q&A box.
Of course, yeah. So I'm going to start with one first question. Do CADASIL patients have higher cysteine levels? Is there a direct treatment for this specific issue? And maybe probably I would like to clarify if you're referring to cysteine levels in blood, or if this is something related to the mutation itself of cysteine-related mutation. But if that's in blood, we necessarily don't address cysteine levels in CADASIL in blood, measuring if it's high or low as a way to either diagnose or treat this condition. But please feel free to clarify a little bit more. And another question, is there anything new on what can we done ahead of time to delay the negative effect of CADASIL, lifestyle, etc., in simple words? Thank you so much for that question. And this is what we sort of like saw in the Cambridge cohort, right? Like addressing things that simple things like stop smoking help a ton, reducing the prevalence and incidence of stroke and dementia. Addressing high blood pressure. We know more that in brain health, having healthier lifestyles, for example, Mediterranean diet, help not only with vessel health, cardiovascular health, but also a structure of the white matter. So simple words, of course, will be if you're smoking tobacco, cigarettes, you can stop smoking. If you have high blood pressure, definitely address those with your primary care doctor. High cholesterol too. And if you are perhaps have different diet habits, I invite you to consider giving up, for example, things like over processed food, maybe try to cook more at home. Increase your fish perhaps consumption if you are not vegetarian. Try to avoid as much as you can red meat, but maybe trying to just spread it out. Cook with and eat olive oil as well, nuts, and avoid alcohol as a habit as well. So those important things are part of a lifestyle that we know that help with brain health as well. I'm going to change to next one. Is smoking medical cannabis included in the umbrella of non-smoking? Or that specifically, this specifically refers to cigarette of like tobacco cigarette, correct? Yes. An attendee said, my brother has it and a number of my family members have it, including my father who was dead at 50. Is this common? I'm not sure if this is referring to CADASIL itself, I assume, but please let me know if that's not addressing the right question. So if there are things that we know that happen as far as like descendant or the autosomal dominant of this condition, perhaps talking to a genetic counselor about how common this is in your family could help us understand the risk of having it as well. So I think that this is an opportunity, also a plug for genetic counseling is absolutely important to understand the risk associated to a family or family members. So if you can talk to your neurologist and have or geneticist to have an appointment with a genetic counselor, that would be my best recommendation. Another question, can CADASIL symptoms be more severe within worldwide ethnicities than other ethnicities, Spanish versus African versus Great Britain? That's a great question. I think that we know that we differ in different things. For example, is Asian ancestry have more tendencies to have more bleeds in the brain? we don't know a lot of our samplers are a little bit skewed towards sort of like the northern hemisphere, so meaning a more European descendant ancestry. So we need a little bit more information of patients with African descent and indigenous ancestries as well, to try to give a little bit more of this information. So that's why it's important, this global collaboration, to trying to understand that. I'm not sure if necessarily severity is something that we understand, because I think that our sample is still a little bit skewed. So we need a little bit more information, but we know that there are differences, and that again adds a little bit more of the complexity of understanding the disease. Yes. Does alcohol consumption affect CADASIL progression? Is there any safe amount of alcohol to consume, like 1-2 drinks a week? It's a tricky question, because I probably will say that from the vascular neurology perspective, that was kind of like an ongoing debate, and perhaps some of you have heard that red wine could be helpful, etc. The truth is that even in different studies, we don't really recommend to drink alcohol when we talk about brain health or brain vessel health. And the truth is that it's a little bit harder to measure that in a clinical trial. And what we know from observational studies is that higher consumption particularly lead to worse outcomes as far as stroke and dementia, and that has a different cascade of like different consequences now. So now we know that alcohol might be related to other diseases, not only cardiovascular diseases, but also maybe neoplastic diseases or cancer. So my advice, personal advice, perhaps is me, Karen Orjuela, speaking right now, would be, if you enjoy maybe socially having 1 couple of drinks a week, that will be okay. If you feel that you are depending on alcohol, you have to drink every day, I probably will say that we need to ask for help in that sense. So I think that would be my best answer. Any updates on active immunotherapy approach at Karolinska? I did not particularly attended this importance for like ongoing research, so I can't answer that question, but I would be curious to know what is happening there. I know that they're part of it, and I didn't mention necessarily this because maybe I haven't had the chance to explore this more in detail, but a lot in neurology field itself is moving towards understanding how our immune system reacts to different injuries, including a stroke. So it wouldn't be a surprise that we add not only the biomarkers, the detection, the gene information, and add another sort of like layer to immunotherapy, meaning that how can we modify the response of the immune system to different insults too. So very great point, and maybe we can take note of that, and maybe in another webinar we can address that. It seems like clinical trials are far off, and I think that I have a cautious optimism. I think that for what we know so far of CADASIL, since it's been a recent sort of like disease, since being sort of like discovered, I think that we now have a little bit more information. I think that we are trying to make the platform ready to think about creating clinical trials that will be relevant for you. So I think that I'm more optimistic. Sort of like in the line of developments, I think that I see that clinical trials are perhaps more in the horizon than ever before. Has data been shared from the adrenaline trial? If yes, can you comment if there was an assessment of efficacy of the data if the data were positive. Yes, it's a publication. I think that I cited on my slides. So that was the researchers were optimistic about the efficacy of that medication. I think that, again, it worked well in that sort of like cohort of patients in East Asia. So thinking about what could be next step in our population, if that's one of the ways of trying something, it could be important to know. Remember that those patients have sort of like a different variation of CADASIL, that they tend to bleed a little bit more. So it would be important to know if for our context, it will be the same sort of like experience as well. Do you know a status of the NIH funded CADASIL research study, like the federal funding freeze? Thank you. So far, I'm not aware of any changes in the current research studies. And please, if someone is here from the studies, let us know otherwise. But so far, I haven't been notified of different changes, at least from the current ongoing studies. But please, if someone is from the studies, raise their hand or send us a comment if that's different. Another question, what is the purpose of testing as a child of someone with CADASIL if we can only follow research and adhere to healthy habits? Absolutely great question. And I think that that's a conversation to have with your neurologist or the geneticist. I think that that's a very fair question. And that has ethical components, right, too, like how someone could understand maybe different changes and what is the impact of having or not the information. I think that each person should be able to understand this better. So perhaps testing earlier where someone, at least in the current state, if someone is a child, maybe we just don't have the right data or information to best advise on that. But I think that if now that we are kind of like trying to gather more data, if you are in an age consentable sort of like a state, it would be an important conversation to have with the geneticist and the neurologist. Absolutely great question, and I totally understand. What would you expect to see on CT imaging for a patient in an active CADASIL episode? Migraine or numbness, dizziness, would there be any obvious that a non-specialist will see? I think that, that's a very specific question, depending on what kind of episode they're looking, but CT is one of the modalities that we use a lot in the emergency department. It's very quick, but it's very non-specific for different things. So I think that perhaps what someone will argue that they would like to make sure that they don't miss is a brain bleed. And that's something that if happens acutely, they could see on that scenario. So if they're thinking that someone could be at risk of having a brain bleed, I think that CT imaging is worth to try in the emergency department for sure. It would not answer all the questions about disease progression, white matter changes, tiny little chronic bleeds that would be requiring another modality of imaging like MRI. Do you have a specific recommendation regarding exercise to help prevent progression? Absolutely. I think that movement is better than no movement at all. So depending on your tolerance and your comorbidities, or if you are, perhaps if you have knee problems, it will be a little bit challenging, et cetera, so personalized. But my best advice is that movement is better than no movement. So if you can walk, what I would probably say, we start with the recommendation from the American Heart Association guidelines as far as all sort of like brain health perspective is like if you walk 30 minutes, like a moderate sort of like exercise for 5 days during a week, that's a great way of like keeping your brain health checked as well. So I think that we just don't have a specific recommendation for CADASIL, but what I would say is movement is better than no movement. If you enjoy biking, dancing, going, maybe avoiding maybe using your car so much, etc., walking to places. If you are in a city where you can use the sidewalks, etc., you can choose that as well. Is mutation in exon 1 rare? I can find information on exon 1 mutation. Maybe that will be something that that I have to review more in detail. How rare is that? But I'm not sure if I will be. It will require a little bit more of me kind of like looking if it's rare really. What about treating CADASIL with calcitonin gene-related peptide? Oh, this is a great point. So one of these calcitonin gene-related peptide receptors is trying to treat patients with migraine symptoms as a whole. There are medications that are helpful in CADASIL that are safe, that are newer, so like migraine agents too. So yes, there is more information about that. How about active immunotherapy to reduce notch-free accumulation in CADASIL? Absolutely, I think that you are in the right track. I think that that's kind of like the next step to try to understand, and not only accumulation, but also how to modify sort of like the signaling of the information. Any updates on whether any clinical trials for treatment of drugs are close to starting in 2025? Oh, that's a great point. I'm not aware of any clinical trials for treatment, but it doesn't mean that doesn't exist. So I will probably say to follow this, I'm just gonna probably share one of these links, clinicaltrials.gov, where all current clinical trials are listed here. So you can look for, I'm gonna put it in the chat. I don't know if we can make it available for all. Amen. So clinicaltrials.gov. You can look for new clinical trials, and they're like they said specifically for treatment, if they're actually launching this year. So all the clinical trials have to be registered in that database. So it's a nice platform to keep updated. From the meetings perspective, I'm not aware, at least in this time, like right now, but it doesn't mean that they're not coming up. For a young woman, my daughter, would you consider taking the birth control pill, put a patient at increased risk? Oh, that's a little bit a loaded conversation. I think that we have to, one thing that I tried to mention during my presentation is personalized care, so in management. I think that is an important conversation to have with her clinician and say and assess if she has migraine with aura, perhaps would not be the best option, and considering maybe family risk, etc. What can they do? So there are multiple ways of doing reproductive health nowadays. So I think that probably that personalized consultation will be best. Could variations in CADASIL disease progression be related to where the effects in notch-free gene are? Absolutely. I think that those are important discoveries that we're trying to answer, and a lot of more of the seasoned teams are trying to find out like where the problem is and how this problem could tell us a little bit more about disease progression and risk of progression too. So about we're gonna have a little bit not only that understanding of the mutation first as a first step, but a little bit more precise of risk progression as well. Yes. Are there any supplements that help with small vessel health? Really great question. I wish I had a great answer, but unfortunately not really tested and approved to be really safe with small vessel health. There are things that we know for some people help with migraines, for example, magnesium, but it's not really a supplement that I would recommend every day because it has some GI adverse effects too. But I think that a good supplement will be or not supplement, but a good way of framing it is like if you can access to supplements like a great food, like avoid like high processed food. I think that that will be a good next step. So having sort of like these fresh vitamins from the source, directly from your diet, a fresh diet could be helpful. Well, this is kind of like a loaded question. Is aspirin okay or not? This is something that we need to start asking in a clinical trial, right? Before, at least in US, we don't have a big cohort of patients where we can analyze if aspirin was okay or not. What we know is from consensus, meaning that researchers, experienced clinicians met and decide whether or not aspirin is okay or not. I will say that depending of what is your background, I mean, if you had a prior stroke or not, if you have tiny little bleeds or not, so it could have different variations. So I will say that it will be personalized approach, and I will probably refer that to your clinician, your neurologist too. Vitamins, again, as I mentioned before. I'm gonna go to the next one. In blood draws is okay. I think that that was in blood draws. Yes, just to kind of like going back to the first question. Not so far, we don't have like a clinical sort of like test so far approved now to check for cysteine specific levels. So that's something that we are looking into the future to have like more biomarkers in blood to try to find pathways of like trying to understand disease progression and response to treatments eventually as well. Yes. Can CRISPR technology help identify biomarkers? I think that we have a huge and a great resource of CRISPR technology that is genetic sort of like engineering. And I think that that's one of the bigger sort of like hopes in different sort of like monogenic disease. And I think that that could be something that perhaps I will let other researchers to specifically embrace as a fully that question. But I think that CRISPR technology definitely is opening a huge door in genetic disease. So I think that I wouldn't be surprised that some teams are starting looking into that as well. I interpret an earlier question differently than you answered. If my father died at 50 from CADASIL complications, does that imply that I am likely to die at similar age? Well, I think that, and again, that question is a great question, but it has to be contextualized to your clinical scenario. It's hard for me, of course, to say yes or no, but I will invite definitely to ask this important question to your neurologist. There are perhaps some things that you are doing really well that will avoid to have that early outcome. So I definitely think that, I mean, being here definitely is something, being informed, something that you're doing really well. So, but it again is an important question to ask to your neurologist too. I'm gonna check with Iman. I have 2 minutes, and I think that I still see a lot of questions coming in the chat. So I'm sorry if I cannot address all the questions.
Yeah, no worries.
But
We can have the questions. They can be sent to me at my email, and which I will type in the chat. And then I will have our clinical core physicians and Dr. Orjuela take a look at those questions and provide the best answer, and we'll post them on our website.
Perfect, perfect. Thank you so much. I think that it was a great questions as well. And we would like to review those and try to answer back to you. There are things that are a little bit more specific, and I invite you to please write down these questions as your neurologist, as your clinical team, your clinical research team, if you have one, to continue to be informed. A lot of these questions help us to ask questions too. So please don't think that any question is irrelevant. So we take these questions seriously as well. So Iman put her email in the chat. So please send those questions your way too. And I really hope that this was informative. I know there's a catalog of a lot of things happening right now. There's a huge portfolio of research out there. So I invite you to keep us informed of your experience and tell us what is important to you and what matters to you. Okay? Thank you so much for being here. I really, really appreciate your presence.
And thank you, Dr. Orjuela, for that amazing presentation. As I said before, if you have any questions that haven't been answered, feel free to email them to me, and we'll have our physicians take a look at those and provide their answers and hopefully make them available on our website. And yeah, thank you again, everyone. I hope everyone has a great evening.
Thank you all. Bye now.